Good morning, everyone. I'm Dr. Arun Mahalingam, Assistant Professor in the Department of General Medicine in Lakshmana Institute of Medical Sciences. So today I'm going to take about the topic of thyroiditis. So thyroiditis is a very important topic. Okay. So in many cases it may be missed. Okay, in many cases usually by the general practitioners it may be missed in the clinical setup. Okay, so it is a very important topic. So the term thyroiditis refers to the inflammation of the thyroid gland. Okay. Thyroiditis means inflammation of the thyroid gland, and it can be divided into three types: okay. Acute, subacute, and chronic. Acute, subacute, and chronic types. Okay. So acute thyroiditis. It is caused by the bacterial infection of the thyroid gland. It is caused by the bacterial infection of the thyroid gland, and it presents with first the prodromal symptoms. Okay, it presents usually with the prodromal symptoms such as fever, fatigue, malaise, anorexia, and myalgia. Okay, so fever and other prodromal symptoms it produces. Okay, and it can cause the painful swelling of the thyroid gland. Okay. Usually, it is radiating to neck and ears, and abscess formation if it is untreated, improperly treated. Okay, so it is caused by the bacterial infection of the thyroid gland, usually produces prodromal fever and other prodromal symptoms, and causes a painful swelling of the thyroid gland, which can result in abscess formation if it is untreated or improperly treated. Okay, so this is a somewhat a dangerous disease. It can cause the destruction of your thyroid gland. This disease can cause a destruction of the thyroid gland if it is untreated properly. Okay, it causes a neck abscess. It causes a neck abscess and can go for sepsis also. Okay. So this is a disease of concern and it requires an immediate parenteral antibiotic therapy. It requires an immediate parenteral antibiotic therapy. Usually we go for third generation cephalosporins. Third generation cephalosporins will be very responsive for the patients. Okay, the patients will be responsive to third generation cephalosporins. You can also use in the sense you can use higher cephalosporins like ceftriaxone, cefotaxime, cefepime, that is fourth generation. Cefepime, cefepime, fourth generation. So any third generation or above cephalosporins you can use for treatment. Okay, and you can use penicillin or ampicillin also. Penicillin or ampicillin also are beneficial in these patients. And due to the severity of the disease, due to the abscess and severity of the disease, patients usually require a care for inpatient care for 10 to 14 days. So we have to admit an inpatient. Patient should be admitted, and we have to do a inpatient. There should be a inpatient care for 10 to 14 days. Okay, 10 to 14 days of antibiotic therapy is required in these patients. Okay, so main aim is to prevent sepsis. Okay, this can cause neck abscess. Okay. Thyroiditis, this acute thyroiditis due to bacterial infection, it can cause a neck abscess if it is untreated. So once you identify this thyroiditis, then you go for a treatment for inpatient treatment for 10 to 14 days in these patients. And second topic is subacute thyroiditis. Because next it is called as subacute thyroiditis. As the name suggests, this is a subacute disease. Usually takes more than 6 weeks to produce symptoms. Okay, acute disease usually less than 6 weeks, and chronic subacute disease is more than 6 weeks. Okay, so it is also called by the other names such as transient thyroiditis, granulomatous thyroiditis, transient thyroiditis, granulomatous thyroiditis, and de Quervain's thyroiditis. So other names are transient thyroiditis, granulomatous thyroiditis, and de Quervain's thyroiditis. De Quervain's is usually commonly used term. Okay. So it is caused by viruses. It is caused by viruses. Acute type is caused by bacteria, and the subacute type is usually caused by viruses. Viruses are viruses which cause upper respiratory tract infection. Viruses which cause upper respiratory tract infection, namely measles, mumps, Coxsackie virus, and adenovirus. Usually caused by viruses which are affecting the upper respiratory tract. Okay. That is your measles, mumps, adenovirus, and Coxsackie viruses. Okay. It can also be precipitated by drugs like interferon and lithium. Okay. It can also be precipitated with drugs like interferon or lithium. Okay. As the name suggests, it is subacute type. So usually symptoms occur usually after 6 weeks. Okay. So what is the disease progression? How does the disease progress? Okay. So this infection, inflammation, drugs or autoimmunity. Okay. Inflammation, drugs and autoimmunity, they cause a thyroid inflammation. They cause thyroid inflammation, which leads to the release of stored thyroid hormone. Thyroid hormone which is stored gets released. Thyroid hormone which gets stored, it is released as colloid, or the hormones are gets released. Okay. So what happens? The released hormones reach the bloodstream and cause a hyperthyroid like state. Okay. Hyperthyroid or thyrotoxic state it causes. Hyperthyroid or thyrotoxic state initially. Okay. Once the hormones are depleted, okay, once the hormones in the bloodstream which are depleted, then the patient goes for a transient hypothyroid state. Okay. So initial hyperthyroid state followed by transient hypothyroid state. Okay. And later spontaneous recovery or resolution occurs. Okay. So again I will tell occurs the infection, inflammation, drugs and autoimmunity. Either of these they can cause the inflammation of the thyroid gland inflammation. Okay. So this thyroid gland inflammation releases the stored thyroid colloids. Okay. Release of the stored thyroid colloids, which leads to initial hyperthyroid state or thyrotoxicosis due to its release in the bloodstream. Okay. And what happens at a particular stage? All these hormones get depleted. And they go for a hypothyroid state. Okay. They go for a hypothyroid state. So initial hyperthyroid state followed by transient hypothyroid state. Okay. Initial hyperthyroid state followed by a transient hypothyroid state, and later after 6 months, usually after 6 months, recovery occurs. Okay, so we have to divide it. Usually, remember the rule of 2. First 2 months is hyperthyroid, next 2 months is hypothyroid, and over the last 2 months, it becomes normal. That is, a resolution occurs. Okay, this is how the disease will progress. So there are 2 types of the disease. One is classic painful type and another one is the painless type. Classic type is painful. Okay, classically it is painful. Sometimes it may be painless also. Okay. So it shares the features of the subacute, acute thyroiditis. Okay. Whichever symptoms seen in acute thyroiditis, it can also be seen in subacute thyroiditis, but the problem is it is a bacterial disease, so abscess occurs. This is not a bacterial disease. Subacute type is not a bacterial disease, it is a viral disease. So usually abscess formation won't occur in this subacute thyroiditis, whereas in acute type, abscess formation occurs. So the other features are all same. Okay, other features are all same. So this also shares the common symptoms like fever, other prodromal symptoms like myalgia, fatigue, malaise. Okay. And it also causes a painful swelling of the thyroid gland. It also causes a painful swelling of the thyroid gland radiating to neck and ears. Okay. And thyroid gland is also, the swelling is there, so thyroid gland is also enlarged and tender. Okay. So as I told, see, first 2 months, patient is in a state of thyrotoxicosis. Patient is in a state of hyperthyroid. Okay. Next 2 months, patient goes to hypothyroidism. And next, the last 2 months, that is at the end of the 6th month, patient's thyroid levels become normal. Okay, so thyrotoxic phase, hypothyroid phase, later normal phase. At the end of 6 months, patients become completely normal. Okay, it resolves by itself. So what are the investigations and findings? Usually, since thyroid is involved, you will automatically go for a thyroid function test. Okay, thyroid function test. So as I told, initial hyperthyroidism will be seen, followed by a transient hypothyroid state. Then at the end of 6 months, usually it becomes normal. Thyroid function and thyroid levels become normal. Okay. Since this is an inflammation, the ESR is raised. ESR is raised. Okay. Erythrocyte sedimentation rate is raised. And due to the release of the thyroid colloids, okay, thyroid colloids are released. So that means you can have a raised serum thyroglobulin level due to the release of the thyroid colloid. It's a mixture of proteins and all. Okay. Usually the thyroid colloids contain thyroglobulin. Okay, proteins like thyroglobulin and all. So these thyroglobulin levels are raised in the blood. Okay. Due to ongoing inflammation, the technetium-99 uptake of the thyroid gland is reduced. Due to ongoing inflammation, the technetium-99 uptake is low. So what is the management? Management is symptomatic only. Okay. Unlike the acute thyroiditis, which require antibiotic cover, this does not require an antibiotic. Okay. The symptoms are only management is only symptomatic. Okay. So for pain and inflammation, you usually start on NSAIDs, non-steroidal anti-inflammatory drugs. Okay. Aceclofenac, diclofenac, ketorolac. Only the NSAIDs usually start. Okay. If there is no improvement with NSAIDs, then we can go for steroids. Then we can go for steroid. That is your prednisolone or methylprednisolone. We can go for. Okay. We will start with the very low dose, 5 mg. In case of methylprednisolone, 4 mg. Okay. We will start with the very, very low dose. Usually, 90% of the patients improvement occurs with NSAIDs itself. 10% of the patients don't have that kind of improvement. So we have to start on steroids on those patients to reduce the pain and the inflammation. Okay. And during the initial hyperthyroid or thyrotoxic phase, we have to give propranolol. Okay. So propranolol, what is propranolol? Propranolol prevents the conversion of T4 to T3. T3 is the most active form. So propranolol prevents the conversion of T4 to T3. Okay. So this conversion we have to prevent using propranolol. Once the patient goes to hypothyroid phase, okay, next to that is the 2 to 4 months, 3 to 4 months. It is a hypothyroid phase. The patient is going into hypothyroid phase, then we have to start the patient on oral thyroxine. Okay, thyroxine should be started only if the TSH levels are more than 10. Okay, if it is less than 10, there is no need to start the thyroxine. Just monitor. Okay, just every 6 weeks you monitor. Okay. Usually the disease may last up to 6 months, so keep on monitoring the patient every 1.5 months. So if TSH is more than 10, that indicates severe hypothyroidism. So start the patient on low dose thyroxine. Okay, low dose thyroxine, that is 25 mcg. Usually start on 25 mcg. Whereas if the TSH is less than 10, there is no treatment is required, just to monitor the patient properly. And chronic thyroiditis. Okay, chronic thyroiditis. The next entity is chronic thyroiditis. It includes multiple entities like autoimmune thyroiditis, Hashimoto's thyroiditis, postpartum thyroiditis, and drug-induced thyroiditis. Autoimmune thyroiditis, Hashimoto's thyroiditis, postpartum thyroiditis, and drug-induced thyroiditis. So first we will see about Hashimoto's thyroiditis. A very important disease. Okay, when it comes to NEET PG also, it is a very important disease. So it is the chronic autoimmune inflammation of the thyroid gland. Chronic autoimmune inflammation of the thyroid gland with the lymphocytic infiltration. So it is the chronic autoimmune inflammation of the thyroid gland with the lymphocytic infiltration. It is the most common cause of hypothyroidism in developed countries like America, UK, USA, UK. In the Western world, that is the Western world. Okay. So it is a chronic autoimmune inflammation of the thyroid gland with the lymphocytic infiltration. Okay, so the thyroid gland is infiltrated with the lymphocytes. Okay, and this is usually a disease of affecting the multiple systems. Okay, it is associated as a disease with the multiple systems. Okay, so some patients may have most of these patients will be they can also have Addison's disease, that is the adrenal insufficiency, Addison's disease, type 1 diabetes mellitus. Okay, skin autoimmune condition like vitiligo and pernicious anemia. What is pernicious anemia? This is a autoimmune restriction of the vitamin B12. Okay, the cells which absorb the vitamin B12 from stomach. Okay, so it may cause pernicious anemia also, and it is more common in women. Okay, it is more common in women. Okay, since it is an autoimmune condition, it has a tendency to affect the women more. Okay, more than men, it affects them more women. Okay. So it causes a diffuse goiter. It causes a diffuse goiter with the firm or rubbery consistency of the thyroid gland. Okay. Diffuse goiter. And unlike the acute and subacute types, it causes the hypothyroid fetches. Okay. Usually subacute type, what it caused? Subacute type caused initial hyperthyroid phase along with the transient hypothyroid phase. Next phase is hypothyroid phase. Okay, but it is a chronic condition and it does not cause any hyperthyroid phase. It directly causes hypothyroid phase. Okay. So chronic thyroiditis usually causes a hypothyroid state. Okay. Rather than hyperthyroid, they go for a hypothyroid state in most of the cases. So what are the investigations and findings? Okay. So yeah, as usual, we are going to go for a thyroid function test. We are going to go for a thyroid function test. Okay, and since it is an autoimmune disease, we have to go for a thyroid antibody profile. Okay, thyroid antibody profile and thyroid biopsy. Usually, thyroid biopsy we won't do. Okay, thyroid biopsy is usually done in previous times, but now it's not indicated. Usually, we limit with the antibody profile itself. Okay, so we have to do a thyroid function test. Thyroid function test T3, FT3, FT4, and TSH. Okay, 3T3, 3T4, and TSH. Usually, T3, T4 may be normal or low. T3, T4 may be normal or low. Whereas patients may have high TSH, very high TSH levels. Okay, very high TSH levels. And 90%, and when it comes to the thyroid antibody, as I told, it is an autoimmune disease, so we have to go for a thyroid antibody profile. So the thyroid antibody profile, what they show? They show a positivity for, there is a 90% positivity in the patients for either of the two antibodies. Either of the two antibodies, that is, first one is anti-TPO antibody, okay, anti-thyroid peroxidase antibodies. The second antibody is called as anti-thyroglobulin antibodies, anti-TG and anti-TPO. Either of them is positive. 90% of the patients, either of these two antibodies are positive. Okay. Usually, thyroid biopsy is not done in routine cases. So, where we are doing thyroid, instead of thyroid biopsy, usually this is done during surgeries. Okay. Some patients may have a very large goiter obstructing the multiple nearby tissues. For example, it may compress your esophagus, may compress your recurrent laryngeal nerve. Okay. When it compresses these kind of structures, then patients usually, what they do, they go for a surgery. Okay. They undergo surgery. And during the surgery, we send the gland for histopathology. That findings are, in the histopathology, you can see this following findings. Okay. So there can be lymphocyte infiltration of the thyroid gland. Profuse lymphocyte infiltration of the thyroid gland with the germinal center formation. Lymphocyte germinal centers which are in the bone marrow. Okay. Whichever is seen in the bone marrow, it can be found in the thyroid gland also. Okay. That kind of picture. And at a particular stage, it will test all the thyroid follicles also. So since it is a chronic disease with chronic inflammation, your thyroid follicles may get destroyed and it may go fibrosed. Okay. So treatment of Hashimoto's thyroiditis. Okay. Since it is a chronic disease with only the hypothyroid picture, only we have to give a supporting management. Okay. Supportive management. Okay. So we have to, due to hypothyroidism, we have to replace the thyroid hormone with the thyroid hormone. Okay. There is no any specific treatment, only thyroid hormone replacement therapy to be done. So this thyroid hormone supplementation can correct the hypothyroidism as well as it helps in the goiter shrinkage. Patients usually have a diffuse large goiter. This thyroxine supplementation can help in the goiter shrinkage. Next entity is postpartum thyroiditis. Next entity is postpartum thyroiditis. As the name suggests, postpartum occurs after pregnancy. It occurs after pregnancy. Why it is occurring? So usually patients have an unrecognized subclinical autoimmune thyroid disease. Okay, unrecognized autoimmune subclinical thyroid disease. So usually what happens in pregnancy? The immunity gets lowered. Okay, the immunity in women get lowered. Okay, immunity of the mother gets lowered. Okay, so so automatically the autoimmune titers also go low. Okay, due to the absence of the immune response, the autoimmune titers also go down. Okay, so immediately after pregnancy, what happens? This immune response gets enhanced. Okay, the immune response gets enhanced. So it will cause an inflammation. Simple. So usually in pregnancy, it goes unnoticed. Usually in pregnancy, it goes unnoticed. Okay. Due to the decreased maternal immune response, it is unnoticed during pregnancy. Immediately after the 6 months of pregnancy, your immune response gets elevated. Okay, immune response gets elevated and enhanced. So this is also comes at that stage only. It is also reflected at this stage only. Okay. This is called as postpartum thyroiditis. Okay. So this also causes hypothyroidism. This also causes hypothyroidism. Okay. As I told, usually it begins in the first 6 months after the childbirth. Begins with the first 6 months after childbirth. Okay. After delivery, 6 months after delivery, usually the disease affects the women. Okay. Sometimes it may occur late after 1 year also. Okay. But usually 6 to 12 months. Remember like that. Okay. And this is a disease of concern because it may persist lifelong also. The disease may persist lifelong also sometimes. So we have to monitor the patient every 3 months. Regularly, we have to monitor the patient whether she is having any, whether the thyroid hormone is monitoring the patient every 3 months once to see whether thyroid hormone supplementation is sufficient or not. Okay, so lifelong, we have to supplement these patients with the thyroid hormone. Okay. So as I told, it is asymptomatic in initial stages. Asymptomatic in initial stages. Okay, only the TFT is deranged. Asymptomatic in initial stages, only the TFT is deranged, and then becomes usually after 1 year of delivery. There may be a mild. Sometimes it's very. Even though it is mentioned, it is very rare. Okay, they come with the presentation of hypothyroidism. Sometimes there may be thyrotoxicosis also. Usually within 1 year, that is 6 months to 1 year, there may be thyrotoxicosis, but there may be after that, after 1 year of delivery, there may be a chronic hypothyroidism. Okay, chronic hypothyroidism. Sometimes it will be lifelong also. So we have to monitor these patients very properly, very regularly. Okay. So what are the investigations and findings? Postpartum thyroiditis. Okay. So TFT, as I told, TFT, there is hypothyroidism, so TFT is elevated. Okay, TFT, that is TSH is elevated. T3, T4, either normal or low, TSH is elevated. Okay. Some patients are positive for anti-TPO antibodies also. Okay. So we saw this anti-TPO antibodies in Hashimoto's side. Okay, Hashimoto's anti-TPO and anti-TG. So in these patients, in postpartum thyroiditis, sometimes TPO may be positive. Okay, anti-TPO may be positive. And since there is a chronic inflammation, okay, the thyroid gland becomes atrophied. Thyroid gland may become atrophied and radioactive uptake will be reduced. Radioiodine uptake will be reduced. So these are the findings in postpartum thyroiditis. The clinical course on the treatment are similar to that of the painless acrobatic thyroid. That is only hormonal supplementation. Okay, other than that, we won't do anything. Only this kind of patients also will be treated with the hormonal supplementation therapy. Okay. Thyroid hormone supplementation. That is thyroxine supplementation. Start with usually a low dose, 25 mcg you start. Okay. If it is more than 100, TSH is more than 100, start directly on 125 mcg. TSH is less than 10, wait and watch. TSH more than 10, start on low dose, 25 mcg. TSH more than 100. Sometimes patients will have TSH more than 100. While presenting itself, they will have TSH more than 100. But TSH more than 100, start directly on 100 or 125 mcg directly. Okay. The next subtopic is congenital thyroid disorders. uh, congenital thyroid disorders are thyroid hormone resistance, disharmonogenesis, thyroid agenesis, ectopic thyroid, and hypoplasticity of the thyroid glands. Thyroid hormone resistance, disharmonogenesis, thyroid agenesis, ectopic thyroid, and hypoplasticity of the thyroid glands. So, congenital hyperthyroidism is a very disease of very huge concern because for adults, they can tell the symptoms. Adults, no problem. They can tell the symptoms of hypothyroidism. They can tell lethargy. They can tell constipation. They can tell weight gain. They can tell loss of sweating, dry skin, okay, bradycardia, hypertension. Lot of symptoms they can tell. But in children, we cannot recognize the disease. So we do a screening test called as Guthrie's test. Okay, screening test called as Guthrie's test. So this the Guthrie's test can identify multiple disorders. Multiple inborn disorders, it is used to diagnose Guthrie's test. Okay. As a part of it, hypothyroidism also recognized. Okay. So basically, there are you will read in pediatrics, but I'm telling a introduction. So basically, there are two types of dwarf children. Okay. One is dwarfism due to growth hormone deficiency, and another one is dwarfism due to thyroid deficiency. Okay. So these children who are having growth hormone deficiency, they are only the height is reduced. Okay. Only the problem is with the height only, but the thing is they are very intelligent. Their intelligence level is more. It's more, and sometimes usually more than normal individuals also. Okay. Intelligence level is more in case of growth hormone deficiency, whereas the patients, the children with the thyroid deficiency, they are called as cretin. It's called as cretinism, and the children are called as cretins. Usually, they are called as cretins. So in these children, the height is also low, and the intelligence level is also low. Okay. Mental intellect is also very low in these patients. Okay, so it is a disease of very huge concern. Should be diagnosed and treated very early. Okay, if you are diagnosing with the positive for the disease means you have to treat it very early. Okay, as I told, Guthrie's test you have to do. The test is called as Guthrie's test. Okay. G-U-T-H-R-I-E, Guthrie's test. So now the recent recommendation is within 2 weeks of birth, the patient is diagnosed with the hypothyroidism, congenital hypothyroidism. Usually within 2 weeks itself, we will start a thyroid hormone supplementation. Okay. And we have to assess these children usually up to 5 years of age, we will assess these children, whether for any intellectual disabilities. Okay. We should assess this patient. Okay. Because this is congenital hypothyroidism from from the pregnancy itself, mother is having hypothyroidism. Okay. Which also affected the child. So we have to check these children regularly. Check these children regularly till 5 years of age. Whether any intellectual disabilities they are facing. Okay. Mental stability is normal. We have to check these children. Okay. Disharmonogenesis. Okay. Disharmonogenesis usually autosomal recessive type of thyroid deficiency. Okay. Autosomal recessive type. The enzyme is called as intrathyroidal peroxidase. The enzyme name is intrathyroidal peroxidase enzyme deficiency. Okay. It occurs in if it is occurring as a homozygous, okay, if it is occurring in homozygous individuals, it may present with congenital hypothyroidism, and if it is occurring in heterozygotes, it may cause hypothyroidism at a later age. Okay. Hypothyroidism at a very later age, after the first 2 decades of life. Okay. Next one is Pendred syndrome. Pendred syndrome, it is a very, very important topic. When it comes to NEET PG, this question is questions get repeatedly asked from this Pendred syndrome. It is a combination of disharmonogenetic goiter along with the nerve deafness. Disharmonogenetic goiter along with the nerve deafness. So remember the name Pendred syndrome. Protein name is pendrin, and the gene name is SLC26A4. Disharmonogenetic goiter along with nerve deafness. Syndrome name is Pendred syndrome. Protein name is pendrin, and the gene involved is SLC26A4. Okay, 26A4. Next disease is thyroid hormone resistance. Thyroid hormone resistance. Okay, this is a very interesting disease. Thyroid hormone resistance is a very, very interesting disease. Okay. So what happens? It is a rare disorder. It's a rare disorder. Okay. So the thyroid hormone, the thyroid hormone receptors are different for it is a different cells. Okay. So in periphery, you will have one group of thyroid receptors, and in central you have one group of thyroid receptors. Okay. Structure is same. Okay, but the function varies. The function and signaling varies usually. Okay. So what happens? There is a resistance in the thyroid receptors of the central nervous system. That is your pituitary and hypothalamus. They have a resistance for there is a resistance at the receptor level of the uh, pituitary and hypothalamus. The thyroid receptor, the sensing receptors in the sensing receptors for TSH in the pituitary and hypothalamus may be resistant to the normal signaling, whereas the peripheral tissues are normal. The receptors in the peripheral tissues are normal. This is the main complaint. Okay. So what happens? It produces a picture like secondary hyperthyroidism. Okay. Your pituitary tumors. Okay. It produces a condition like your pituitary tumors. Okay. Secondary hyperthyroidism. Okay. So what happens? All the TFT, okay, that is the T3, T4, TSH, all are raised, all are high. Okay. So this is the mechanism. Okay. Only the hypothalamus and the pituitary are selectively unresponsive to the negative feedback mechanisms. Hypothalamus and pituitary are selectively unresponsive for the negative feedback mechanisms. So what happened? There is an increased TSH level. TSH keeps on increasing. Okay. Only hypothalamus and pituitary are selectively unresponsive for the negative feedback mechanisms. Okay. So it keeps on secreting the TSH, and this TSH is going to keep on acting on the thyroid gland. Okay. So what happens? Increase T3, increase T4, and increase TSH. Everything is going to be increased. So due to the resistance, what happens? These normal thyroid hormones act only on the peripheral tissues without any resistance. Resistance is only at the level of central nervous system. That is your hypothalamus and pituitary. There is no resistance at the level of peripheral tissue. So it is going to function normally. All the peripheral tissues are going to function normally. Only the resistance at the central nervous system, at the level of central nervous system. So it is going to keep on secreting TSH, unable to respond to the negative feedback. So TSH is going to keep on secreted. And this leads to thyrotoxicosis. Okay, due to increasing secretion of T3 and T4, the patient goes to thyrotoxicosis. Okay, this is called as thyroid hormone resistance. Resistance is at the level of central nervous system only. All the peripheral thyroid receptors are unaffected. So, as I told, difficult to distinguish from the TSH producing tumors, that is your pituitary tumors. Okay. So, whenever a patient is having increased T3, T4, and TSH, go for a MRI. Okay. Immediately, make sure the patient is not in any under debilitating condition. For example, some ICU patients also can show this kind of hormonal abnormality. So, make sure the patient is not recently admitted in hospital or not undergoing a stress or what. Okay. So, always the T3, T4, and TSH levels are raised. Okay, too much high. Just a minor alteration is okay, but everything is too much high. T3, T4, TSH too much high means you have to go for a MRI. Okay, do MRI. MRI tumor is there, then it is called as secondary hypothyroidism due to tumor. No tumor is there, MRI clean, and then it is thyroid hormone resistance. So MRI is the differentiating factor between the thyroid tumors, that is the pituitary tumor and the thyroid hormone resistance. If MRI is positive for tumor, then it is positive for secondary hypothyroidism. No tumor in MRI, then it is called as secondary, then it is called as thyroid hormone resistance. Okay. Thank you.